Good evening, everyone. I hope you are able to see my screen and hear me clearly.
Yes, we can.
Okay, lovely. To begin with, I'd like to say that I have no financial interest in the product mentioned. And just to begin with, just a little story. Documentation is what is very important nowadays, and especially with the medical legal era we have already entered. It is becoming more and more important to document whatever we are doing. So traditional fundus cameras cover up to 30 to 40 degrees of posterior pole, and imaging beyond traditional was first introduced by ETDRS when they introduced 7 standard fields, and it covers up to around 75 degrees of retina. However, a large part of the retina still could not be imaged, and most of the peripheral lesions we could not document. All we could do is image it with the draw it with color diagrams, which have a huge subjective variability. So now we have different wide field systems, and Opto's imaging system is what I'm going to talk about. Uh, One recent update on the subject is that recently there has been a classic consensus definition that anything which beyond images beyond the equator in all 4 quadrants will be considered as ultra wide field, while anything which does not cover it beyond the equator will be called wide field. Now, Optos is basically a confocal scanning laser ophthalmoscopy, which using a virtual point technology and ellipsoid mirror gives us fast, uh, uh, in a very fast manner, non-contact images of the retina, which are high resolution and can provide us the same images through a very small pupil also. We know that it uses 2 monochromatic lasers of 633 and 523 nanometers. Now we have Optos California, which can give us additional ICG images, and Optos have come up with the latest model, that is Silverstone, which gives us a wide field swept source OCT scan of around 23 millimeter. Now, just a very few cases to begin with, before I go to the individual diseases. This is a young male, 20-year-old, who came to us with the slight deterioration of vision. Vision was 6/9, and we could see that there is the epiretinal membrane. And of course, we tried to capture the posterior pole and surrounding retina with the help of 7 standard fields, but we could not find any abnormality. And then we sent the patient to our lab for the further imaging. Optos imaging, we can see that there in the periphery, there are some abnormalities. So subsequently, we went on to do FFA of this patient, and we can see on the steered images in the temporal periphery that there are multiple aneurysmal telangiectasia of the peripheral vessels, indicating that this was a patient of Coats disease which has developed telangiectasia, and that has secondarily led to epiretinal membrane on the macula. So that way we could find the cause of the epiretinal membrane in this particular patient. So this is another patient, again a 20-year-old male who had a full thickness macular hole at the posterior pole. And the patient vehemently denied the history of trauma. Neither were there any signs of trauma at the posterior pole or in the anterior segment. So we went on to image this patient, and we could see in the periphery, there are some vague pigmentary changes, which on fundus autofluorescence did show that there are some hyper and hypoautofluorescence, with some hyperautofluorescence at the macula. The other eye was normal, absolutely normal. So we came to conclusion that this patient must have had a trauma, which patient could not recall. Again, a young female who presented to us with a macular hole with bilateral disc edema. Now, just looking at the posterior pole, the diagnosis is very difficult to make out. But a single wide field image, we see a cysticercus in the inferior cavity. This patient had a neurocysticercosis along with a cysticercus in the vitreous cavity, which probably came into the vitreous cavity through a macular hole. So this is just to summarize few of our cases where ultra wide field really make a difference in the diagnosis and subsequent management of these patients. Now, coming to individual disorders, I like to show these images again and again. This is a middle-aged male who presented to us with neovascular glaucoma. You can see that optic atrophy is there. The patient has undergone panretinal photocoagulation, decent amount. And if you see carefully on the top, there is anterior retinal cryotherapy scars, which patient had undergone. But in spite of all this, the patient progressed and went on to become PL negative. If you do the ultra wide field imaging and FFA, you can see there are large areas of capillary dropout which have not been addressed in this particular patient, and that is probably why this patient kept on progressing. So this is the other eye of the patient, 618 vision, poorly dilating pupil. This is what we could capture on a conventional FFA. There are large areas of capillary dropout at the posterior pole, but if you do ultra wide field, we can see that it's fairly well lasered, but ultra wide field fluorescein angiogram shows that there is persisting NVD and large areas of capillary dropout, which still not needs to be addressed. So this patient is at the risk of developing to the same fate of the other eye if we do not treat such patients adequately. So again, coming to this patient with proliferative diabetic retinopathy, you can see an angry looking NVD and a neovascularization elsewhere along with pre-retinal hemorrhages. But the moment we turn on to the ultra-wide field, we see that whole of the periphery has been knocked out. And this patient is very high risk for progressing to neovascular glaucoma. Of late, we have been getting reports that we get two kinds of diabetic retinopathy. One is predominantly posterior diabetic retinopathy, where the anterior retina is predominantly normal. On the other hand, we get another kind of diabetic retinopathy where 50% of the actual lesions lie anterior to the seven ETDRS 7 standard fields. So this indicates more risk of progression, though at this stage we don't know who are the patients who develop predominantly posterior disease and which are the patients who develop disease anterior to the equator. So in diabetic retinopathy, ultra-wide field is very useful for exact localization of the non-perfusion, quantification of the non-perfusion, and it may act as a guide to targeted laser therapy, though it has not found its foothold in the management of diabetic retinopathy. Early detection of peripheral NV is another useful thing we can do with the help of ultra-wide field image. Coming to venous occlusions, this is a patient with the BRVO. You can see multiple NVs. I found a disc and put a blue circle around it, and then I tried to fit the black area that is capillary dropout with all these blue circles, and see there are around 60 circles which we could fit. So traditionally in a BRVO, we've been taught that 5 disc diameters of non-perfusion is significant. But with wide field, we know that this is much underestimated, and actual non-perfusion required for patients with vascular occlusion is much higher to go on to develop neovascularization. In CRVO, now we know that greater than 75 disc diameters of non-perfusion is high risk of neovascularization, while 30 disc diameters is low risk. However, there are no set guidelines in the setting for BRVO. So again, have a look at this image. On a cursory look, it very much looks like a diabetic retinopathy, proliferative diabetic retinopathy. We have a neovascularization of the disc and neovascularization elsewhere. But if you see all the lesions, none of them are at the posterior pole and they are in the periphery. So we know that we are dealing with a case of ocular ischemic syndrome and not proliferative diabetic retinopathy. And hence it becomes a very important teaching tool. Again, have a look at this particular patient. Looks like patient has a CRO with the attenuated arteries and cherry red spot. The FFA shows that there is macular infarction and there is an NVD. We do believe that on these findings that patient has CRAO, and OCT confirms our diagnosis. But look what we found on ultra wide field imaging. There are triangular areas of hyperfluorescence which are referred to as a malaric sign, and it indicates patient does not only have retinal artery non-perfusion, the patient is also suffering from choroidal hypoperfusion, and these are choroidal infarcts. Coming to vasculitis, this is something we have worked on. This is a patient who has undergone decent amount of laser, but see whole of the periphery has been knocked out and there is persisting NVD. This patient underwent ultra wide field guided complete laser and NVD promptly regress. So in our study, we found that ultra wide field imaging is excellent for the documentation of the peripheral lesions in these eyes. It is again very good for some of the peripheral vascular disorders like FEVR, where the pathology lies in the temporal and the nasal periphery. And you can see there is exudation, there is peripheral avascularity, and the neovascularization, which can be very well assessed on the ultra wide field angiography. So coming to some of the other capillary hemangiomas, retinal tumors, which are not so uncommon in a tertiary care referral center, while these lesions are very easy to put on naked eye examination, these small lesions are something which can be picked on ultrawide field angiography. And we know that it is easier to treat them when they are small. Once they grow out uh, of their bounds, it's very, very difficult to treat these lesions. So it becomes very useful to pick these peripheral small lesions and treat them early. And we have found certain novel findings in these patients and reported earlier. Coming to a patient of uveitis, this is something Aniruddha showed earlier. Again, a patient of young female who was in her second trimester, had multiple spots at the posterior pole. Of course, we could not do angiography. Did have wide field autofluorescence. So we can see these hyper autofluorescent spots which are emanating from the disc and going to the mid periphery. We know that this is a patient of mutes and does not need to be treated and will recover on her own with the passage of time. Other kind of uveitis, for example, CMV retinitis in this particular patient, while this is little atypical because the disease is posterior and is a case of leukemia, but once the disease progresses, ultrawide field is an excellent tool for monitoring of progression of these cases. We all have read about Toxocara granulomas, but have never documented one. So this picture gives us an excellent idea of how the disease pathology is and acts as an excellent teaching tool for the postgraduate residents. Again, you can document the peripheral findings in the setting of high myopia in cases with retinal detachment where the montaging techniques are very difficult. So again, this is a patient with giant retinal tear, and this patient was aphakic and had no lens. We could not use oil in this patient, underwent vitrectomy with gas tamponade, and we could see that patient had attached retina, and hence this acts as a good patient education tool. And one advantage of ultra wide field imaging is that we can look through the gas bubble as well. Coming to dystrophies, it has shed new light on the pathophysiology of dystrophies like PPRCA. Earlier, we have reported that these are actually the form frustrate cases of retinitis pigmentosa, since the autofluorescence pattern resemble RP, and over a period of time, these eyes can go on to develop retinitis pigmentosa. Some of the dystrophies like Stargardt disease, which have been thought to be a macular disorder, with the advent of ultra wide field imaging, we know that these dystrophies go on to involve the periphery of the retina, and ultra wide field is very useful for the detection of these peripheral abnormalities. And again, we have published regarding that something where it will be very difficult to make a montage, but with a single click, we can capture the whole of the periphery. You can see the pigmented abnormalities in the para arcade area. And if you see on OCT, there are skytic areas. We know that we are dealing with the case of Goldman-Favre. So in congenital disorders, it's very useful since the patients tend to have poor vision, nystagmus, and non-dilating pupil. So conventional imaging modalities may be difficult. Ultra-wide field is an excellent tool for the monitoring of the peripheral disease in these cases. But everything which has roses come with thorns, so it has certain limitations. It has only red and green lasers, so no true colors. So it may be a problem when the color of the lesion is important to distinguish the subtle pathologies. Again, we are striving to be better. 360 aura to aura view is not available or visible in with these equipment, but nowadays with the machine has inbuilt software, we can make automated montages of the steered images. Superior and inferior retina are not so well imaged, and of course there are inherent problems of projecting a curved surface onto the flat surface, so that leads to peripheral distortion and the measurements are not correct. And of course, most important is the cost, and it is not so widely available in all the practices. Just a single case about wide field ICG, an elderly male hypertensive who was found to have a peripheral RP rip in the right eye, and the left eye showed some irregular staining on FFA. So when we did ICG in this eye, we could see that the well-defined polyps in this eye, and now we know that peripheral polyps are a common occurrence in these eyes of PEHCR. So to conclude, ultra wide field is an efficient, fast, non-contact method of obtaining high-quality images. It is excellent tool for a documentation and monitoring of the peripheral pathology, and has definitely provided new insights into the peripheral retinal disorders. Thank you.